the principle of oxygenation-sensitive MR goes back to the so-called BOLD effect. BOLD stands for blood oxygen level dependent, and it simply reflects the phenomenon that deoxygenated hemoglobin has a paramagnetic effect on the immediate molecular environment. So this paramagnetic effect, if you use a T2 star sequence, will lead to a signal drop. So what it means that if you have a dynamic change of the oxygenation of hemoglobin, this will be visible as a change of signal intensity with a spatial resolution that we can achieve NMR. So that's the bare principle. An oxygenated hemoglobin has a very small diamagnetic defect, so it acts a bit differently, but the main effect is that of deoxygenated hemoglobin. So what we therefore can say is that what we are seeing in these images, the changes we can observe, reflects what is happening on the deoxygenated side. That's mainly the venous side of the capillary system, which is abundant in the images as we see them. So, and of course, the deoxygenation is a function of the relationship between supply and demand. And there's also what we have now seen very clearly, a change across the cardiac cycle. So this is very exciting, and we'll talk more about that later. So BOLD imaging, or BOLD sensitive imaging, has been used in the brain since 1990 when it was introduced as functional MR. One of the early clinical studies that we actually performed in the beginning of this millennium, already a while ago in Berlin, could show that the principle works. At that time, the image quality or the with an EPI readout was not necessarily consistent. But fast forward, with the support of collaborators such as Rohan Dharmakuma at that time in Chicago, we were able to implement a cine sequence. Is this a regular cine sequence, an SSFP sequence, just with some modified parameters? And these modified parameters are mainly echo time and bandwidth. So no special sequence required, just a modified version of the sequence. And when using this is just one of the papers, we could show that when given adenosine, there is a change of course, the blood supply is the vasodilator that reduces the relative proportion of deoxygenated hemoglobin that leads to signal intensity increase. But this is blunted in areas that are subtended by a stenotic coronary artery. And here, work by Judy Liu, performed in Calgary, showed that this separates very well patients with or without hemodynamically severe coronary artery stenosis. So that is just to show that the principle of oxygenation-sensitive MR is applicable to the heart. In fact, the signal intensity change is 5 to in healthy people up to 15 or 20%. So it's much stronger than what the brain offers for functional MR, which is more in the 0.5%. So this is this allows us to do that, although the heart is moving and comes with all the challenges. So then we took it one step further. And this was work that was very much supported by work of research fellow and student Dominic Günsch and Kady Fischer. Kady will give a talk later, so where we implemented that. But it goes back to an observation that that I had made, and that's just reflecting physiology. And this is maybe the most complex slide that you have to go through with, but it's important to understand. If you increase carbon dioxide or you reduce it, you change coronary blood flow. Why? Because carbon dioxide acts as a vasodilator in the brain and the heart. And in the brain and the heart almost exclusively. So there is nothing, there's not a lot of reaction to change of carbon dioxide in the muscle, for example. but you have that in the heart and the brain, which means if you get rid of carbon dioxide, because carbon dioxide is a vasodilator, you get into a more constrictive physiology, which means you hyperventilate. With hyperventilation, you reduce carbon dioxide, and then that leads to a decrease of coronary blood flow by about 25%. And then the opposite happens when you hold your breath. You do not breathe off the carbon dioxide. It accumulates, acts as a vasodilator in the brain and the heart, and you have an increase of coronary blood flow. And even after 30 seconds, and it of course goes on, but even after 30 seconds, you have then a net increase of coronary blood flow of about 100%, which is remarkable because this is comparable to what you can do with intracoronary adenosine injection. So this is the reason why we use the following protocol to actually introduce a so-called perturbation. So we change the system to have predictable reactions of the vascular system, which we then can track with oxygenation-sensitive MR. So we go from normal breathing for a minute to hyperventilation for 1 minute, which technically means 30 deep breaths in and out, where each takes 1 second in, 1 second out. And then in end expiration, that's very important. And in expiration, you have a breath hold, because when you expire, then you do not have a lot of earth surface left to get rid of carbon dioxide. So your carbon dioxide will increase relatively fast. If you do that in inspiration, this is a larger surface. So there is still some carbon dioxide could get transferred to the air. So this is the protocol that we have been using, and we have applied similar protocols. This is in athletes, where we could show that breath holds lead to an increase of change as expected, and hyperventilation leads to a decrease. Then we have compared it. This is work by Kady Fischer at the Montreal Heart Institute. We compared it to adenosine and could show that the effect is actually stronger than that of adenosine IV. And you could also see why there's a significant scatter in healthy or apparently healthy people. There is a predictable plateau that is reached after about 25, 30 seconds, because that's when there's basically the system is sort of saturated. Whereas in the blood, in the same slices, there is not a lot of change. So this is in the same images, so it's not an effect of whatever heart rate or whatever you might want to invoke here. So then we went ahead and performed animal models that could show that when you introduce a planned coronary artery stenosis, and and there was a fantastic work from Dominic and Kady Fischer, also at the Heart Institute. These data could show that the hyperventilation breath hold method actually can identify the areas that cannot vasodilate because there's significant coronary artery stenosis. So they are already vasodilated. If you have a stenosis, there's peripheral vasodilation, so it will not dilate further. And it also doesn't constrict because there's acidosis and metabolic stuff going on. So it also does not. So there is no real response. In fact, it leads to a relative decrease because the other coronary arteries basically steal the coronary blood flow from there. Then the feasibility was then demonstrated. This is work from the Inselspital in Bern, that indeed, if you use color maps to show that you can easily identify the coronary arteries that cannot perform this vascular response, as opposed to a remote territory that behaves like healthy people and show this response. Some of these results have been in one way or another repeated by others. So work from Germany, from Ulm, for example, from Oxford. Then Garth Beach in the US did that. Here's a paper from Harvard. They saw that in patients with arterial hypertension, a different or a blunted response. And this is a paper from China, where they, even after a 10-second breath hold, they could differentiate various tissues. We also had applied breathing maneuvers without oxygenation-sensitive MR, using ultra-fast strain images. And this is a work from Heidelberg, Marco Ox, compared to adenosine. this breathing maneuver led to a change of strain that was significant different between ischemic and normal myocardium, and a test that just took very little time. Kady Fischer in Bern also applied this to patients with heart failure. It was a collaboration between Bern and Montreal, and could show that the response to the breathing maneuver was, together with the circumferential strain, the most frequently observed abnormality in patients with heart failure. So adding this to a test that allows for anatomy, function assessment, tissue characterization, the combined application, so the oxygenation sensitive MR can add significant additional knowledge. And because we do not have a good test for non-invasive assessment of vascular function, this is clinically really relevant. The only gold standard test for that would be the injection of acetylcholine into the coronary arteries, but this is of course highly invasive and also comes with some risk and significant inconvenience. Now, I want to briefly also mention that last week we published a paper. It was presented at last week's Journal Club that could draw a line between heart failure, specifically reduced cardiac output, and reduced cognitive function using this approach. So both sensitive imaging, in this case in the heart and the brain, with breathing maneuvers. And there was a clear message that depending on the cardiac output, cognitive function is associated with microvascular dysfunction in the brain and the heart. Just to briefly mention, we also looked at how do the patients appreciate that, and the doctors, and both patients and doctors would prefer by a large margin such a test as opposed to pharmacological stress or CT angio or stress perfusion MR. We presented at the last OS-CMR. We presented preliminary data from the BMOR trial. It's an international multi-center trial. And in the meantime, we have about 120, if I'm not wrong, are recruited all in all. And just very briefly, oh, sorry, am I on the wrong slide here? So what the data could show that, and I apparently forgot to put in the slide, that using machine learning, we can achieve a diagnostic accuracy of about 90% to correctly identify the coronary territory. So these are preliminary data, but it's a blinded analysis with an automated analysis. So this is very robust. I also want to mention, Kady may in her talk mentioned that too, combining oxygenation and strain in the same images, again, gave, in this case, an area under the curve of 0.91 to correctly identify coronary artery disease. So this is the protocol we're using, and the protocol has been published in the Journal of Visual Experimentation. So you can look that up if you're interested. Of course, we are always available. Now, the fun stuff for the future will probably include something like that. This is what we currently call the oxygenation cardiogram, because the oxygenation apparently changes across the cardiac cycle, and has a different profile when you're healthy or when you have a patient with coronary artery stenosis. You see the whole profile is blunted, and the territory that is most significantly affected is specifically bad. And then, of course, adding to the mix artificial intelligence. These days, nothing much works without artificial intelligence anymore. Allowed us to then to achieve these, oh, here's the slide, achieve these data. So while the specificity is 80.8%, which is still very good compared to other imaging modalities, the sensitivity is outstanding with an area under the curve of 0.899. So this is just to provide a little bit the background of what we can do with BMOR. Or the breathing enhanced oxygenation sensitive imaging. Of course, this is the more the sunny side. There are also things like you have to take care of shimming. You have to make sure that your patients breathe properly. So there are things to talk about, but any stress test is reliant on standardization and the quality of the data. So with this, I want to conclude here, and with yeah, we're a little bit behind time. I apologize for that, but I thought it would make it easier for the others then to tack on that and talk. And the next talk will be from fantastic young lady. She was a student in Montreal and is now back in Lebanon, and is at medical school, and she is performing and is almost finished with a program using oxygenation sensitive imaging in patients with anxiety. So this is a very exciting area. So I would ask Mayssa to share her screen and calling in from Lebanon. Thank you very much.
Thank you so much, Dr. Friedrich.
Sorry, just give me 1 second. In case there is any question or remarks, you feel free to post this in the chat, so that we can respond to that and see that. Okay, thank you. Sorry, Mayssa, go ahead.
Okay, thank you so much, Dr. Friedrich, for this amazing introduction. So, as Dr. Friedrich mentioned, my name is Mayssa Moukarzel, and I did my master degree under the supervision of Dr. Friedrich. And today I'll be talking about the breathing-induced myocardial and cerebral oxygenation in anxiety disorder, or the BGLAD project. So this project was done in close collaboration with Dr. Hillier, Mitchel Benovoy, Margherita Leo, and Dr. Friedrich, all here present today. So 1 in 4 Canadians will have at least one anxiety disorder in their lifetime, making anxiety the most common mental illness in Canada. Anxiety is defined as a persistent feeling of apprehension, and beyond this well-documented emotional dysregulation that we see in people with anxiety disorder, anxiety has also been associated with the cerebral hypoperfusion and cognitive impairment, but also with the onset and the progression of cardiovascular disease. Now, despite this increasing prevalence of CVD that we see in patients with anxiety disorder, the exact mechanism linking anxiety and CVD remain unknown. However, there are several hypotheses pertaining to the heart-brain axis that could explain this trend further. So patients with anxiety disorder have been shown to have an altered autonomic control, which is composed of the parasympathetic nervous system and the sympathetic nervous system. Now, once you have a bit of stress or a stressful stimuli, what happens is that your sympathetic nervous system is activated. So you're going to have release of epinephrine and adrenaline that will cause increasing heart rate and increasing blood pressure and vasoconstriction. But then once the stimuli has passed, or after a certain time, you have a nice homeostasis or a nice balance between the PNS and the SNS, where your physiology go back to normal. However, if your body is subjected to chronic stress or anxiety disorder, your sympathetic nervous system is always going to be overstimulated and activated. So in that sense, you're going to have at all time an increasing heart rate and blood pressure and vasoconstriction that could lead to endothelial dysfunction. And this is really what BGLAD wants to focus on. It's the endothelial dysfunction that could happen in patients with anxiety disorder. As you're all familiar here today, so cardiac magnetic resonance imaging is a non-invasive diagnostic tool that makes use of systematic application of radio frequency and strong magnetic field to observe and obtain high-resolution images of the heart, notably where we can look at morphology and function. We can also look at the blood perfusion, and we can also look at tissue oxygenation with OS-CMR. So as Dr. Friedrich mentioned, so the OS-CMR can be used in tandem with breathing maneuvers that are vasoactive stimulus, can replace this pharmaceutical vasodilatator. And in that breathing maneuver, again, you have a period of normal breathing, then a period of hyperventilation, then a period of breath holds. And we can take from that the important biomarker for us, which is the breathing-induced myocardial oxygenation reserve, or BMOR. And it's really just the ability of the tissue to oxygenate themselves when in need. and it has been shown to be lower in patients with impaired vascular function compared to healthy individuals. So what about breathing maneuver in the brain? CO2 is also a strong endothelial-dependent vasodilatator selectively in the brain, which gives it the potential of this method to be used in the brain as well, introducing a novel cerebrovascular biomarker, which is the breathing-induced cerebral oxygenation reserve, or BCOR. As Dr. Friedrich mentioned, the similar approach was used in a fantastic work by Liz here to assess the oxygenation reserve of both the heart and the brain in patients with heart failure. And it was shown that patients with heart failure had both a lower BMOR and a BCOR compared to healthy controls. Now back to our study, the BCLAT study. Our aim is to assess the impact of breathing patterns on myocardial and cerebral oxygenation in patients with generalized anxiety disorder, or GAG. And as a secondary objective, we also wanted to see if CBT, which is a therapy widely used for GAG, improves or reverses those cerebral and or myocardial oxygenation response in patients with GAG. So in that prospective cross-sectional observational longitudinal study, as of for now, but we're still in the process of recruitment, we have 12 patients with GAG, 5 participants in the subgroup. So those are the participants who have GAG, but who follow also the CBT, and they're going to have a follow-up scan 6 months after their first scan. And then we have 11 healthy individuals that are sex matched and age similar to the patients. As per the inclusion criteria, of course, we have to have a confirmation of a GAG by professional practitioner, also no history of other psychological disorder, and the patient will be excluded if they use any short-acting anxiolytic medication 24 hours prior to their exam, because it has been shown to affect vasculature. Now, for both healthy and experimental groups, so they have to be non-smoker, between 18 and 55 years old, no history of pulmonary and cardiovascular disease, and no MRI contraindication. So how did the study happening? The first step is basically a screening step, and it's done by the Emotional Health CBT Clinic, that is a clinic affiliated with the McGill University Health Center, where a clinician will assess the presence and the severity of GAG with the use of PSWQ questionnaire. And then when we're sure that they're eligible, they came for a visit at the hospital where they did a bunch of questionnaire, notably the CUCSOS, KUDOS, and MOCA questionnaire that assess respectively the anxiety severity, depression severity, cognitive impairment. Then they had the MRI exam. So they had OS-CMR in the heart and the brain in conjunction with breathing maneuvers, of course, to assess respectively the vascular function of the heart and the vascular function of the brain as well. Then for that subgroup, so the patient that followed the therapy, they had a similar scan, so a mirroring scan and questionnaire around 6 months after their first scan. So for the image analysis for the heart, we use the OxySense module to assess the global and regional myocardial signal intensity values. For the brain, we did the pre-processing steps using a software called FSL, and I'm going to get into this later on. And then to assess the global cerebral signal intensity values, we use MATLAB, thanks to the amazing work of Mitchel right here, who developed the code to make this analysis possible. For the statistical analysis, we use SPSS to do a bunch of tests and basically to look at BMOR and BCOR across the different groups and to investigate the associations. Now, this is just a little visual summary of the breathing maneuver that we did in the heart and the brain and its effects. And here, I just want to mention that the brain breathing maneuvers was done twice just to ensure reproducibility of the method and to reduce any variability if there was any. Now, for the pre-processing steps of the brain, the first step was the denoising, which means basically creating the brain mask. And you do that again in FSL with a high resolution T1 3D anatomical sequence, in our case, MP-RAID. And basically, you remove everything that is non-brain tissue. So for example, here the skull, and you end up with something like that. And then from there, we can do registration. So you align the OS image in the orientation and the space of that T1 weighted image, so the MP-RAID, for accurate anatomical localization. And we also do normalization. So you work this MP-RAID to a standard reference space, such as MNI. And we can also do segmentation. So segmentation, you create different tissue masks. So this, for example, is the gray matter mask, and then the white matter mask, and then the CSF mask, and then the three together. And this is interesting because we can look at the signal intensity across the different masks of the brain. So then we also did a reduction of noise in MATLAB with the help of Mitchel again. So we did a motion correction and a baseline correction. And this is just to show really, basically the, for some reason, the video is not playing. But basically, we ran the signal intensity across time, and we saw that there was a certain physiological response. There was a certain physiological response to it, and certain pulses that we thought could be attributed to the cardiac pulses, and it was very positive for us. So then we did big core image analysis. So we took the white matter and the gray matter mask, and we looked at the signal intensity across the different region of the brain, just to see if there was any variation of the signal intensity across the brain. And so here you could see, for example, for the gray matter, that the ACC part of the brain had we seem to have a higher signal intensity compared to the rest of the brain. Just something I want to note here is that the OS image is acquired in 2 slices. So this is the images of the 2 slices and not the whole 3D brain. So this, I think, was the most relevant thing for us, is when we plotted really the signal intensity across the phases or the time. And in what we call OEG, or oxygenation encephalogram. And we wanted really to look at the variation of the signal intensity across time, to see if we would observe what we expected and what we also see in the heart usually. And we did. So basically, this is the signal intensity during free breathing 1. You can see the deciliter variation. And then you have decrease of signal intensity during hyperventilation, which is what we expected as well. And then we have an increase of signal intensity for the breath hold. And then you can see the same pattern for the second breathing maneuver. Now, as for the B-core calculation, we did a lot of different trial and errors to really find the B-core that was the most representative of the tissue oxygenation of the brain. And we ended up with that calculation. So we took B-core as being the percent change of signal intensity between the maximum signal intensity closest to breath hold and the minimum signal intensity closest to 0 second into breath hold, or really the end of hyperventilation. So then once we done this statistical analysis, we saw that between GAG patient and healthy control, there wasn't any really difference between the baseline characteristic between them, except for the diastolic blood pressure. So GAG patient had a higher diastolic blood pressure compared to the healthy control. And then looking at the mental health and MRI measure, we could see that the GAG patient had a significantly higher CUXOS and KUDOS measure, as we would expect, which are, again, the anxiety severity and depression severity. And also they had a lower B-more mid, B-more global, and B-core global compared to the healthy control, which you can appreciate here in the figure. So we can see that the GAG patient had a significantly lower B-more compared to the healthy control, and also a significantly lower B-core compared to the healthy control. So then we did also a Pearson correlation between the CUXOS and the B-more, and the CUXOS and B-core, and we found moderate negative correlation between these factors. Now here, this is looking at the CBT result. It's very preliminary. We just have 5 participants, but there seemed to be a nice trend here. So we can see that patient post-CBT had a lower CUXOS and KUDOS score compared to patient before their CBT. And also they had a higher B-more global compared to before their CBT. And they also had a lower diastolic pressure compared to before the CBT. Now, comparing the patient after their therapy and to the healthy control, there seemed to be no difference in any of the measure, except, of course, for the number of sessions, since the healthy control did none. And this is really to appreciate that. So we can see that there seemed to be a trend toward GAG post-CBT showing a higher B-more compared to before their therapy. And again, no difference in the healthy control. So again, for this therapy, it's preliminary result, but I think it shows the potential of the therapy. And I want to finish off here by saying that BGLAD overall shows it can showcase a great potential of the application of OS, not only in the heart, but in the brain as well, and how we can use OS to furthermore elucidate this heart-brain axis and give more info into that. So yeah, here are my references. And thank you so much for listening, and thank you to my team.
Thank you very much, Mayssa. So in case you have questions, just feel free to speak up or post a question in the chat. I think these are very exciting data. It allows us to understand why a mental disease and even diseases as frequent as general anxiety, how they affect vascular function and therefore may also affect cognitive function. So we will certainly continue with that, but this I will at the end ask a question where people are interested in terms of the research. I think the heart-brain axis here deserves a lot of attention, and this is a fantastic way. We will actually, together with team in Ottawa and other teams in Montreal, and in Hamilton, perform a large project on the heart-brain axis, which will include oxygenation-sensitive MR of the brain and the heart. So there's certainly more to come. So then we're running back in time, so I asked the others to really not go over time. So we have the next one is Glisant Plasa. He's also a student and has done some fantastic work while being with us. And he's still associated with us. He still is involved in even developing the software. So it's a fantastic teamwork that he contributes a lot to. So his work was on exploring the options of introducing machine learning in evaluating the oxygenation sensitive images. So Glisant, take it from here.
All right. So can everyone hear me?
Yes, we can hear you.
Perfect. So thank you so much, Dr. Friedrich, for that. And good morning, everyone. My name is Glisant, and today I'll be hopefully sparking some interest with some of the work that we've done at the CMR lab of the MUHC. So in this current study, like Dr. Friedrich mentioned, we attempted to combine artificial intelligence with this powerful imaging technique of oxygenation-sensitive cardiac resonance, or OS-CMR, in order to collect important markers for disease state, and then further use them for precise patient classification. This was work that was done in close collaboration with Dr. Hillier, Leo, Benovoy, and Dr. Friedrich. So the aim of this study was to create a pipeline that facilitates working with OS-CMR data, as well as to adapt the current protocols that are used in our lab to the new wave of artificial intelligence. So you've heard about OS-CMR, but just a quick overview. It's an imaging protocol that we use in our lab that allows us to non-invasively measure oxygenation changes in the myocardium. With OS-CMR, our participants have to undergo a breathing protocol, breathing maneuver, that ranges from normal breathing to hyperventilation, followed by a breath hold. And across these changes in breathing state, we get a change in vascular tone from normal to constricted and then dilated. This is something that we can measure as oxygenation levels, and then use the signal intensity or change in oxygenation levels to create our data sets and then further train our machine learning algorithms. So in the recent literature, as has been mentioned, OS-CMR has shown amazing potential in investigating diseases across different pathophysiologies. But in this study, we focused specifically on classifying patients presenting with obstructive coronary artery disease. So previous preliminary work done here at the lab by Dr. Hillier showed that just using statistics and computer vision can be sufficient to show a difference between a heart of a healthy volunteer and a diseased heart. And again, this is very qualitative, but we can see clear differences when we have regional abnormality in terms of signal intensity. But we wanted to take this work a step further and apply machine learning to assess whether it is possible to train sort of a model that can do this classification all by itself. So some of the results that I'm presenting today were actually published at the American College of Cardiology in March. Okay. So our pipeline here begins with our amazing technicians that collect all the data through the OS-CMR scans. In this study that I'm presenting, we had a total of around 115 participants, with approximately half being patients and half being healthy volunteers. Now, to give you an idea, with our current data extraction protocol, with each of the scans that we take, we get around 3,500 features or data points per patient, of course. And so the second step, of course, consists of using artificial intelligence to mine through the thousands and thousands of OS values and extract some key cardiac regions that might be affected in the target cardiac disease. So this is referred to in the literature as feature selection. Once we've obtained these biomarkers or these features or data points that are important, we can now focus on them and train neural networks and decision trees in our current study to classify a patient from healthy participants. Okay, so what does this look like? What we do is that we take the same machine learning classifier, again, in our case, it was a random decision tree classifier, on 2 different data sets. One of these data sets is formed from 10 selected markers, or SMART markers, featured selected markers, and the other data set from 10 randomly selected ones. So I think this figure here provides a simplified example. Let's say that we have a data set with 15 different data points. We will split that into 5 randomly selected features, and then 5 intelligently selected features using our algorithms. Of course, for the random features, we'll have to do an N distribution because, of course, we want to better capture what it would look like to select 5 or N random features. So again, with this method, now we have 2 different data sets that we can feed into our machine learning models and see how they perform on these featured selected features and these random features. Okay. I think this becomes clearer here. What we see in these graphs are the randomly selected features for data set 1 and 2 and the distribution for healthy volunteers and patients presenting with coronary artery disease. And what we can see from the distribution here is that there's not a large difference on these random selected features. However, when we move on to the MIC and ANOVA selected features, and these are just different methods that we can use to conduct feature selection, what we clearly see is that, especially for data set 1, across the different 5 selected features, the distribution for healthy and patients with CAD is very different. Okay, we've kept both of the feature selection methods because we found that for some diseases, it might work better to use MIC or ANOVA. Okay. So the metric that we use to measure accuracy is the area under the curve, which for those who are a bit unfamiliar, it just takes into account true positives and false positives. And what we saw is that with randomly selected features or markers, we average 0.67 IROC score. However, when we use our 10 selected features and use the exact same parameters for the model, we increase this score to 94% at discriminating between a patient and a healthy volunteer. So it's an incredibly more advantageous method. So the logical step here is to follow the finding and conduct a case-selective feature sensitivity analysis. That is to say, how does our accuracy change while we increase the number of features that we select for? So here, each line will correspond to the accuracies of MLP, which is a multilayered perceptron or a neural network-based approach for classifying between a patient and a healthy volunteer across multiple case-selected features that we see on the x-axis. So we went from 5 selected features all the way to 50 in steps of 5. So we can look at this graph for a few hours and pull a lot of information out of it. But I think the 2 main takeaways, at least for us, were that while our feature selection approach will outperform random features as well as all features in classifying patients across the different number of features that we select, but also that the cardiac disease that we've presented in data set 1 seems to be clearly easier to classify than that presented in data set 2. So data set 1, I didn't mention this, but so data set 2 was a validation data set that we introduced, which is patients that are born preterm. Nevertheless, in both cases, we see that combining feature selection with our machine learning classifier improves accuracy for classification. Okay. The bottom line is that AI can indeed be combined with OS-CMR to battle cardiac disease. And we've showed that using our feature selection, we can classify patients with an accuracy of 94%. I think in our case and in this day, what is even more important is that our automated pipeline can do all of this in less than 10 minutes. And this compared to traditional manual analysis time for students that take 170 hours for a patient course of this size. And that doesn't even include training that you need to conduct these analyses. Of course, machine learning is not magic. We shouldn't treat it as such, and we shouldn't want it to be magical. So there's a lot more work that we need to do before we can trust it to make clinical decisions, but we should adapt our techniques continuously so that we can improve our understanding of disease state and provide better patient care. We're, of course, in the study limited by our cohort size and disease states, but we plan on refining our algorithms, including more diseases, and test the robustness of our methods. So with that, I think I've concluded everything I wanted to say. I want to thank my team for their amazing work. Thank you all for your attention.
Thank you very much, Glisant. So I think this paper or this work really beautifully highlights the huge impact that machine learning, so artificial intelligence in general, has, especially when identifying patterns that may not be accessible to the human eye. So I think that's very important to realize that some of what we're doing now exceeds the capacity of us just looking at the image and saying, oh yeah, there's a bright spot here or there. So I see in the chat, it's already very active. Thank you very much to Mayssa, and also for the other speakers for being available for answering the questions directly. And if there are questions that we should address with a verbal conversation, just let us know. So then, in the interest of time, let us move on and go to the Swiss Alps, where Kady Fischer, who was a PhD student and has now her own research team at the Inselspital and is performing amazing work, and of which she will today talk about perioperative CMR of inducible myocardial ischemia during a general anesthesia. And this is really fantastic work because it allows, in a very controlled environment, to actually observe physiology and understand not only what we can do with oxygenation sensitive MR, but also the physiology, in this case, of inducing general anesthesia. So Kady, thank you very much for joining, and take it from here.
So yes, hello everybody. So thanks. Just before I start, I'd like to just make some disclosures that our studies are funded by a few organizations here in Europe. And mostly I'll be talking about our first publication from this study that was in the British Journal of Anaesthesia that was published this summer. And so this is actually one of our top journals that belong to the field of anesthesia. So I think if you've noticed, we aren't cardiology and we're not radiology, we're cardiovascular anesthesia. In our hospital, one of the larger hospitals actually in Switzerland. So we have more than 400 people in the department. But specifically, I work with Professor Gunch here, and we have our own team of study nurses and clinical researchers, and a great crew also of medical masters and dissertation students who have worked on this. I think about 7 who passed their stats exam yesterday, so they're pretty happy. So anyway, yay. Right now, most of the OS-CMR talks are really on diagnostic uses, looking for underlying cardiac heart disease. But for us, we're actually more concerned about what's happening in the OR. So did you know, like many patients, as you get older and you have more cardiac disease, these are undergoing surgery as well. And it's not just a typical cardiac surgery, it's also knee surgeries, hip surgeries, anything that puts them in the OR. And these patients, almost half of the adverse events during the OR are cardiac related. And this results in hundreds of thousands of cardiac events and quite a few that are life-threatening. So this is often attributed to what we call inducible perioperative ischemia. So I think we've learned already that this is occurring when oxygen supply to the myocardium is not meeting its demand. And we have a couple of abbreviations here in anesthesia. We have MINS, so that's myocardial ischemic injury and non-cardiac surgery, and then MIX, which is in cardiac surgery. So why is it important to investigate the heart during anesthesia? So I mean, the first thought people think about is probably the actual anesthetics themselves that are cardiodepressants, maybe some are stimulants that increase workload, a lot have vasodilatory effects. And I always like to show this because this is a really nice stock picture of what you see in anesthesia, or maybe what you see on TV. If TV maybe doesn't even show the anesthetist. However, this is an actual major cardiac surgery. You can see there's a lot more factors at play here. So we, of course, like to look at blood gases, which we will talk about later, CO2 and oxygen changes. These can occur with changes in breathing patterns, also ventilation, so when the anesthetist is controlling the pattern. And also you have to think about what's happening during intubation as well. Of course, other factors can impact the heart, such as fluids loss, blood pressure control. And we don't even need to consider we should start considering what's happening on the other side of the drapes over here with the surgeons. And this is including pain stimuli, blood loss, hypercoagulation. So it's a very, very complex heart scenario for the heart. And so perioperative myocardial injury and ischemia is a big topic in anesthesia. Actually, I know Hamilton and the Institute de Cardiology de Montreal are some pretty big players in this. And so, for example, a study here from Basel had over 7,000 patients. So these are patients with heart disease, and that they ended up having a rise in troponins during the surgery or after the surgery. So this is how we normally quantify perioperative myocardial ischemia. And they actually classified the majority of these injury events are actually due to type 2 ischemia. So this is just a supply-demand mismatch, so not an infarct that we see here or extra cardiac reasons. And 17% of these that had a recognized type 2 ischemia ended up actually having a MACE or all-cause death in 1 year. And so this is actually quite high. And so the way we measure perioperative ischemia is through troponins. But you guys probably know already that this is normally takes 24 to 72 hours as our guidelines to measure any rise. And of course, we can't actually pinpoint when the ischemic events occurred because it's monitoring the whole perioperative phase. Additionally, troponins represent cell necrosis and irreversible injury, so it would be much more ideal to measure the earlier markers of ischemia. So we can actually overcome both these limitations by imaging. We already do perioperative echo in the OR, but with MR, we want to go one step lower and look at the myocardial oxygenation deficits as well. So that's the goal of our research here, is we want to apply OS-CMR to really continuously measure changes in the tissue oxygenation during the injection of general anesthesia. And our main goal is really to pinpoint triggers for perioperative inducible ischemia. So specifically in this paper I'll talk about, we focus on the induction phase because this is the time frame when patients are put to sleep. And because within a period of about 15 minutes, there's multiple breathing maneuver changes, intubation, positive pressure ventilation, and many anesthetics and medications that are given. So it's a very vulnerable time for the heart, yet we still don't even really know what's happening. So before we get to the exciting parts, I just want to quickly show a submission under review. And this is also some work from our dissertation students as well. And on the left, we see this rapid pace maneuver. It's been explained to you quite a bit. But before we can monitor the heart for 15 to 20 minutes in anesthesia, we needed to develop and validate a free breathing oxygenation sensitive sequence. And we could do that here, and you see, as it's shown before, hyperventilation decreases oxygenation with a rebound to surplus during apnea. One more component is, while this rapid pace breathing maneuver is quite aggressive, this isn't what we do during induction. So normal induction period is paced but deep breathing for 14 breaths per minute, followed by 5 deep breaths. And if you look at our continuous imaging here, we actually get the same trend, just at a slightly slower rate until we receive a plateau of a deoxygenation. And then once again, apnea has the same effect. So this is our images. So you can see here why we don't use the traditional segmented approach for OS-CMR imaging, because in the bottom left, we obviously can't get any good images while the patients are breathing. And apparently breathing is important, I've been told. And then we have our free breathing variants here, one that's a single shot. So we only get a diastolic frame, but high resolution, and our more important real-time cine loop here. So we apply these latter two both in our study. So right now I'll just talk about the case report that is publishing the first 2 patients, but this is actually a major prospective observational trial. So we take 14 heart healthy patients. So these are all people scheduled for general anesthesia and orthopedic surgery. So they basically have very low risk of cardiovascular disease, and 14 patients scheduled for coronary procedures. And this would be a risk factor score of 3 to 4 ASA PS class. So we take them, we induce them inside the MRI, and then they get transported to their normal surgery. So these are all people that were actually scheduled for general anesthesia. No one's volunteering to get the drugs. So anyways, what happens is the patients come to the MRI, we do all the patient prep in one of the prep rooms, and then we actually do basically 10 minutes of a baseline exam. We do some mapping, we do some functional analysis, and the patient's still awake at this time. And then we actually start the induction procedure. So I'll just quickly summarize the general induction procedure. We follow the same pattern for all our patients. We will now give the patients an oxygen mask. If you don't know, oxygen is also a vasoconstrictor, but it's common to give 100% or 90% oxygen beforehand, so you can oversaturate the blood, basically, or saturate the blood. Patients are breathing for 2.5 minutes, as we said, and then we start giving the sufentanil. At this point, patients will normally slow down their breathing, and we give propofol and rocuronium, and at this point, the patients will stop breathing, and the anesthetist will take over with the bags. And then with apnea, The patients will have some apnea of about 30 to 60 seconds during intubation, after which they're put on a ventilator. I always say this is positive pressure ventilation because you are fighting against the pressure of the ventilator. And this is with sevoflurane. And then we send the patients to the OR. And the whole time, the entire time, we're imaging mix of OS-CMR images. So just to tell you, this is a pretty complex procedure. We do have a lot of safety backups. We had to have lots of meetings before we could even start this, but it is a quite interesting study. But generally, we have 4 to 5 senior anesthetists that are with us per patient, and a few nurses as well, along with study teams. And you can see here, they're bagging the patients and ventilating and intubating right in the tube at the back of the bore. Well, we have another team that monitors all their computer equipment and information that can't go inside. And so here is a video. Oh yeah, it's working. So you can actually see that this is in the Vita scanner, so it's a bit larger, that they're intubating right at the back. We give all our anesthetists also headphones, so it's a bit harder to communicate than normal. And you also have to understand they don't have as good a view or access to the patient as they would obviously in the OR. So this is why we only have the senior anesthetists do this. And we have a bunch of MR compatible equipment to perform this. I won't go into it. We do have a bunch of backup methods in case the intubation doesn't work. And then they will attach the patient to the ventilator, and then we just scan for 10 more minutes just to monitor the recovery from intubation. And the whole while, as I said, we're doing the continuous acquisition of images. So here the patient's already on the ventilator, everything's calmed down, and they're just asleep at the moment. So this is a type of images we can get. So we also can account for the different breathing patterns, depth in breathing, heart rate that changes with the drugs as well. So then just a quick summary of the results. So the first one is a heart healthy patient. They are a little bit obese, so they are a bit higher on the ASA schedule, or ASA, risk stratification, and they were scheduled for knee surgery. They had pretty normal function. We did some non-contrast-free mapping to show everything was within normal ranges. And so I apologize, this is going to be a busy slide, but if you have more questions after, you can email me or read our case report. But anyway, the green zone is when the patient is still awake. They have an oxygen mask and they're breathing deep. And we have the same effect we see in just the normal diagnostic studies. Oxygenation is dropping here on this bottom curve with an increase in heart rate. And the advantage is we also can measure the end tidal CO2 and respiration rate as well. Then what happens is we start giving the medication. The patients start to reduce their breathing. Their CO2 rises as they slowly stop breathing. And you can also see a rapid increase in the oxygenation here that occurs with this patient. Then at that point, the anesthetist takes over with the manual bag ventilation. This almost mimics hyperventilation. So once again, we have a drop in CO2. I think it went from 40 millimeter mercury to about 20 in this patient. And they're also normally going a bit higher pace. So you can see again, oxygenation drops. And at about this point, they go on to the ventilator. And despite just the steady state CO2 steady state breathing rate, sorry, saying the German word, patients remain deoxygenated for about 8 minutes. And in the last 5 controls, it's about 7 to 9 minutes before they recover back to baseline. And what's interesting is we can also do the strain in this, as Matthias talked about before. So we can see increases and drops in strain, but we see no regional effects. Everything's homogeneous across the heart in this patient. And then we see a slight reduction in strain by the end of maintenance, and this is also known with echocardiography studies and likely due to the cardiodepressive effects of anesthetics. And then it's also interesting now to compare it to CAD patients. So this is a patient scheduled for invasive direct coronary artery bypass. They're only 51 years old. And also what's interesting, this patient was characterized by CT and angiography. And they also had a type 2 anomaly. So it means that LAD actually perfused a lot more of the myocardium than in a standard patient. And FFR was also done in the cath lab as well. So they had a hemodynamically significant lesion. Still, their baseline cardiac function was 56%. And they didn't actually have too abnormal mapping either. So again, just to remind you, the anterior wall and the whole septum were categorized by the invasive cardiologist as being perfused by the stenosed LAD. And they also had fairly normal echo findings preoperative as well. So what we see is the exact same thing with the healthy people. Pre-oxygenation eventually leads to a deoxygenation in the myocardium, associated with a significant drop in CO2 and tidal CO2. Once we start giving the medication, the patients slow their breathing and CO2 rises here, and we see a recovery in the oxygenation back to baseline. We don't see a surplus like we see in the healthy controls. And then again, manual bag ventilation is exactly the same as hyperventilation. And here we start to see a regional differentiation, especially with strain here in the LAD territory. And then immediately post-intubation is when we really start seeing differences. So by mid-maintenance, what you see here is the whole anterior LAD perfused zone shows deoxygenation. And we now have significant strain heterogeneity as well, especially in the post-stenotic tissue. So just to summarize, this is really the first findings to actually use CMR to investigate the heart during GA induction. We see that there are really complex oscillations of myocardial function occurring during induction, and this is both in the healthy controls and the CAD patients. And then especially in the CAD patients, when we see dysfunction and strain co-localized to the oxygenation, that leads us to think this could be the onset of some inducible ischemia. And we also are collecting blood markers that we'll compare later. And then our findings do suggest that significant blood gas fluctuations during GA induction, whether intended or unintended, do increase the cardiac vulnerability in these patients. And we're going to keep recruiting patients so we can really evaluate when deoxygenation and strain deficits occur with certain procedures during induction. So in conclusion, we really hope that by implementing advanced CMR into anesthesia, we can really understand better the cardiovascular pathophysiology in anesthesia. And this should hopefully actually help us derive better protective perioperative strategies for patients at higher risk for perioperative cardiac events. And then, yes, I would like to thank our team because it's a very administrative intensive procedure here. And I think there's some questions in the chat.
Thank you very much, Kady. Fantastic work and congratulations, and respect for what you have pulled off there and what you also could learn from that. So my first question would be, what is for you, what were the most important takeaways from this experience in terms of whether the protocol that we are using should be modified? I saw that, for example, the plateau that was reached during hyperventilation was a little bit later than what we first had observed. So it took about, in this case, about 1 minute or 2 minutes. So did you draw any conclusions on whether the protocol could be modified to improve it further?
Well, so in this specific study, I don't want to get too much into the protocols because during the deep breathing, we are starting to administer medications and everyone responds quite different. So, I mean, you can see like some people can make it right to the end of the deep breathing phase with the 5 deep breaths, and I can see that in their images, they're breathing deep. And some probably like 20 seconds after sufentanil, their breathing has just stopped. So yes, that's the advantage of the continuous imaging and the continuous monitoring with the CO2 and the respiration rates.
Okay, thank you very much. One last question. Did you have also now a lot of experience with all sorts of patients? So there's always the question, okay, can they really hold their breath long enough at the end? Isn't this a limitation? What do you think? Is this a problem? Does a significant proportion of patients have difficulties holding their breath long enough to get a diagnostic turnout?
So in this specific study, by the time the patients are holding their breath, they're pretty much anesthetized. So they don't really have too much control in the rebreathing, which is also very nice for the imaging. So at that point, the anesthetists are actually taking over. Otherwise, in other studies, I mean, every patient is different. And I think it depends on clinical versus research-based. But it's not really. In this one, all the participants are aware they're coming for CMR. And they're honestly only awake for 5 minutes. And we talk to all these patients after the next day or in the afternoon based on when they wake up. And they're all quite happy and don't even remember starting the MRI procedure.
Yeah. Okay, fantastic. Thank you very much, Kady. Say hi to Dominic and continue with the great work. And oh, hi, Dominic. Good seeing you. So it's great that you put, and I think what also deserves an extra mention is that the huge impact this has on the understanding of anesthesia and reduced risk. We all went through the phase when I was a young doctor. It was totally obvious to give every coronary patient 100% oxygen. And we have learned over time that this may not be a good idea, and you provide now the basically the physiology background of why we should not do that, and then you take it now one step further and go through the different phases of the anesthesia, and which will eventually reduce risk for patients. So fantastic work! Thanks again and also for joining. So the next one, I want to call out Katherine Lindsay, a student from our team, who has dug her nails into normal values and patients with metabolic syndrome. So share to us your data, Kate.
Thank you. I'll go ahead and share my screen. Can everyone see the screen?
It is relatively small. I don't know whether it's just on my side, but oh no, it's probably on my side. Okay, don't worry. It's all good. You can see
Okay.
it.
Great. So hi, everyone. As Matthias said, I'm one of the students in the lab, and I'll be sharing some preliminary work from my PhD thesis project titled Metabolic Risk Factors and Myocardial Oxygenation Reserve. So when we think about vascular function, there's not just a healthy state and a disease state, but truly a whole spectrum of variation in between. And a lot of that is based on risk factors that the individuals have. So there's multiple different factors, but we can start by discussing non-modifiable factors. So factors that affect everyone, like an individual's age, their sex and sex-based factors, and their genetics. There's also what's known as modifiable factors. So those can be behavioral considerations like tobacco or alcohol consumption, an individual's diet, or their physical activity level. And then, of course, there's metabolic factors that are measured clinically, like hypertension, diabetes, cholesterol, waist circumference, or other blood biomarkers. Now, these factors can promote inflammation in the body, leading to increased risk of cardiovascular disease over the lifetime or other cardiac events. And when we talk about metabolic risk factors, there's also something known as metabolic syndrome, a combination of common modifiable atherosclerotic risk factors. This syndrome is characterized by characteristics like abdominal obesity, high triglycerides, high systolic blood pressure, low HDL cholesterol, and high fasting glucose or diabetes. And we can diagnose it if an individual has at least 3 of those things. Now, what does this cause? Well, metabolic syndrome over time can induce vascular dysfunction in the body through a variety of pathways. There's, of course, genetic and environmental factors, as well as those metabolic factors I mentioned earlier, which combine and create a pathway of inflammation, progressively leading over time to things like vascular dysfunction or atherosclerosis. So how can we monitor these changes in vascular function that might be subclinical before the onset of coronary artery disease? Well, as you guys have heard through the previous talks today, oxygenation-sensitive cardiac MRI, or OS-CMR, is an effective non-invasive way to assess vascular function. And as introduced by the other speakers today, when we use this technique with breathing maneuvers, it's effectively a completely non-invasive way of measuring the vascular function in CMR just by breathing. So no injected contrast, no pharmaceutical vasodilation, just an individual breathing in the scanner, and we can assess their vascular function. So previously, I took a look at the BMOR, so our biomarker, in healthy individuals. And I saw that even in those healthy individuals, their BMOR values did vary slightly. They were slightly reduced in female individuals, they increased in people who were taller, and they decreased slightly over the lifetime. There's been other research from Dr. Judy Liu, who works in our lab as well, who did OS-CMR in a risk factor cohort. And what she found was super interesting, that individuals with risk factors have this blunted myocardial oxygenation response to adenosine during their OS-CMR, even if they didn't have coronary artery disease. So even in individuals who don't have overt CAD, they still show reduced myocardial oxygenation as a marker of their vascular function. And I want to build on this work by first studying a metabolic syndrome cohort and also using our breathing maneuvers as the vasoactive stimulus instead of an injection of adenosine. So in that way, I'd like to assess BMOR as a marker for coronary vascular function in the individuals who have metabolic syndrome. To do this work, there's two branches, a retrospective observational branch and a prospective branch. So first, starting with the retrospective branch, we worked with the Courtois Cardiovascular Signature Program here at the MUHC, and participants from around Montreal and elsewhere would enroll in this program by filling out online questionnaires. After that, they would take an OS-CMR exam with breathing maneuvers, and I was able to retrospectively identify them and gather their data based on the questionnaires they had filled out originally, and then analyze their images to obtain the BMOR. Simultaneously, prospectively, patients were seen at the MUHC Metabolic Center under Dr. Sherman, and I was able to identify patients with metabolic syndrome through medical record screening. After that, I would invite them to take an OS-CMR exam with breathing maneuvers and again measure their BMOR. So for this study, I aim to have 59 subjects per group, but I'll present today just a preliminary analysis. This analysis is of, again, our BMOR biomarker, and we measured it globally, so in the whole myocardium, as well as just in the basal slice and the mid slice, and then in the different layers of the myocardium, so subendocardial and subepicardial. And we also took a look at how the BMOR values varied around the myocardium, so the regional heterogeneity. And we assessed that by calculating absolute differences between the different segments of the myocardium. So now on to some preliminary data. So for our study population included in this analysis, we ended up with 19 individuals with metabolic syndrome. 9 of those were female, and they had a mean age of 56, and 20 healthy controls. Half of those were female, and their mean age was 53. One thing to note here is that the mean age didn't differ significantly between the control and the metabolic syndrome group. So first, taking a look at BMOR globally and in the different slices. The basal slice BMOR was actually significantly reduced in patients. The patients had a mean BMOR of around 3.6, compared to controls who had a mean BMOR of 6.8, and this was statistically significant on a t-test with a value of 0.04 for the p-value. But if we look at the mid-slice and the overall global values, there was no statistically significant difference here. Even though we did observe the trend that you can see where the metabolic syndrome group had consistently lower values, but it wasn't statistically significant. So then we took a look within each group and saw if the values varied between the myocardial layers. And we found that in each myocardial layer, the values were consistent between the two groups. So you can see that here between the overall values and the values divided by the subepicardium and subendocardium, there was not a lot of variation. So then we compared the myocardial layers between the two groups. And similar to the mid and global results, again, there was a trend of lower BMOR values in the patient group, but this wasn't statistically significant. So you can see that in this graph as well. So following that, we wanted to take a look at the heterogeneity. So we started with what we call radial heterogeneity. So to assess this, we looked at the sum of absolute differences between the same AHA segment in the endocardium and epicardium. So you can see that in this image here. And in this case, the values were very similar between both the metabolic syndrome and control group. The mean value of the metabolic syndrome was about 17%, while it was about 14% in the controls. So after that, we took a look at the circumferential heterogeneity. So to look at that, we looked at the sum of absolute differences between adjacent segments. And in that case, the metabolic syndrome patients had a significantly higher heterogeneity. So their mean was around 77 compared to about 60% in the controls. And this was significant with a p-value of 0.03. Lastly, we wanted to look at longitudinal heterogeneity. So this was the heterogeneity between the segments of different slices, so between the basal and the mid. And in this case, again, the values were increased in the patient group, who had a mean value of around 87% compared to 56 in the controls. with a p-value of 0.01. So this was actually the first study to look at myocardial oxygenation in a metabolic syndrome cohort. As I said, previous work has looked at myocardial oxygenation in risk factors, but that was with adenosine, and it hasn't been looked at with breathing maneuvers until now. We observed a trend towards reduced BMOR in the patient group. This was seen throughout all the results, but it was only statistically significant basally. So maybe it could be that the basal slice could be impacted differently from the mid, such as due to blood flow, or maybe we just need a larger sample size to confirm if this is a true trend. We also observed a heterogeneous regional response to breathing maneuvers in the patient group. So we saw this longitudinally and circumferentially. This result actually supports previous work done in an ANOCA population by Liz Hillier and her colleagues. They found that in individuals with ANOCA, their BMOR values were actually consistent with healthy people, but the ANOCA population had increased heterogeneity, like in this study. And they suggested that their regional heterogeneity could reveal underlying microvascular dysfunction in that population. So maybe the same thing is happening in metabolic syndrome, with the BMOR values remaining relatively consistent, but regional heterogeneity being increased. If we think about the scale of vascular function going from healthy to cardiovascular disease, maybe regional heterogeneity is the parameter that's affected first, and then discordant BMOR values could emerge later with more overt pathology, like we've seen in heart failure and CAD in other literature. This work wasn't without limitations, so the results showed a significant inter-individual variability. I'm currently performing a test of the test-retest variability on the 3T scanner that was used in this study. So it's possible that the variation on that scanner is high just due to baseline variability, but that's to be seen. Other factors could also affect signal intensity and contribute to that, like B1 inhomogeneity, and we're currently testing a correction for that as well. Also, as this was a preliminary analysis, the sample size could also contribute to this. Lastly, this work only looked at BMOR and the heterogeneity. There's a lot of other CMR-derived parameters that I'd like to include in my full analysis. To continue this work, I'm going to be performing additional analysis with the full sample size of the study. And I'd also like to derive the myocardial oxygenation profile across the cardiac cycle. So that's that oxygenation curve that previous speakers referred to, rather than just looking at BMOR. So this will allow us to characterize the risk pattern and the healthy pattern of oxygenation across the cardiac cycle. And we can then confirm different populations against that curve to see how they vary. That analysis will also give us more sensitive biomarkers through parameters derived from the pattern or curve itself, and using machine learning, like the cardiome algorithm from Area 19 that Glisant mentioned, to give us more salient features to discriminate between healthy individuals and those with metabolic risk factors.
Thank you very much. Oh, sorry.
Almost done. So overall, we can conclude that the patients show a heterogeneous, overall reduced response to breathing maneuvers, contributing to our understanding of vascular function. And this could suggest that BMOR may reveal the underlying impact of risk factors on the myocardium. Thank you.
Thank you very much, Kate, for this overview. So, of course, a question that seems obvious is the variability is relatively high. So while there is some evidence showing that there is indeed a high individual variability of the responsiveness, that may be a very sensitive marker for vascular fitness. And so some of that is for sure physiology, but of course there's a concern how much of that is technical. So maybe I would also ask Liz Hillier, who you worked with and who completed her PhD and is now a medical doctor, who will speak later. Liz, you have performed a reproducibility study earlier. Maybe the two of you can comment on how much of that could still be technical or protocol related or whatever motivation of the participant, so that we can get a feeling where the variability comes from.
Kate, do you want to comment first?
Yeah, I think that there are a variety of sources for the variability that it could be. I think Well, in the healthy volunteers that we assessed, it was with like self-reported factors. So it's possible that there was some variation just due to their physiology that we weren't able to capture in these statistics. But also it could be due to the signal intensity on the images itself. So like I mentioned, the B1 inhomogeneity is something we're looking at as well, and thinking of incorporating a correction for that. And then there's also could be variations in contouring or things like that. So I think that when we have the software from Area 19 that Glisant mentioned, that it'll also be interesting to see if the values like become less variable with that as well.
Yeah, I agree with Kate. And this is just a snapshot of a figure that from a paper that we've actually submitted on the reproducibility of the breathing maneuvers, just showing we put the same participant in the scanner and just kind of made them repeat the breathing maneuvers after a period of 3 minutes between them. And so we looked at both the hyperventilation and the breath hold, and just looked at the signal intensity and then the correlation of both. So the breath hold correlation being over here, and the hyperventilation or response to hyperventilation correlation being over here. So our values are quite high, over 0.8 for both, over 0.85 for both actually. So I think that part of it is center experience. We've seen that when we don't onboard centers kind of properly or provide the right kind of instruction, I think that's probably the most important thing here. I think the technical reproducibility of the sequence and the performance itself is probably okay once the training is good. And I find that the training of the participants is so key here in terms of performing the breathing maneuver well. And I know we're running behind time, but Lucas Weberling also just turned on his camera. I'm calling you out here, Lucas, but maybe you can comment as well on your experience, because you've moved from a site that has done some to done quite a bit.
Hi everyone. Yeah, well, that's key. I can totally agree. So you have to. We do a combination of so actually we have some sites who run completely without doctors who are with knowledge in OS-CMR. So it's just to do that remotely from Heidelberg, and it's all key. So we do some with the iPad. We do some advisory, and the patients look the videos at home. They get to see it again before the CMR, and then we have the technicians again telling them and testing them really. So that's key. So just yeah, again and again to tell them what to do, and yeah, we have the best results of that.
Okay, thank you very much. So Liz, you have already your next talk hopefully up. So a short report on first results in preeclampsia in a collaboration with the Christ Hospital in Cincinnati. So Liz, take it.
Thanks, Matthias. Can everyone see my screen?
Yes.
Fantastic. Okay, I will try and make this a short report, as you mentioned. One of the things when we were putting together this symposium is, obviously we have this new special interest group in this consortium of these sites globally. And one of the things that I think is important to highlight is a successful collaboration. We're obviously doing a lot here at McGill, but we actually partnered with the Christ Hospital in Cincinnati. And so this is results from them. So these studies were not performed at McGill, so this is totally from a different site that has successfully implemented this, and there's some exciting work coming out of this. So as Matthias mentioned, I did my PhD with him. I did medical school at the University of Alberta, where I'm now a resident in internal medicine. We did this study in collaboration, and the site lead is Dr. Odema Quesada, who's a kind of cardiologist who specializes in women's heart health. And what we're looking at in this study is hypertensive disorders of pregnancy. So that includes preeclampsia, eclampsia itself, and HELLP syndrome in the most severe end of that. We mostly looked at the preeclampsia kind of sub-cohort of this study, and we ran OS-CMR in these patients. But just for a little bit of background, I won't kind of belabor this, but preeclampsia is kind of a hot topic right now. It's been associated with increased risk for cardiovascular disease, either within the decade or even decades after the unaffected pregnancy. And the underlying pathophysiology of this is unclear, but it could be related to some inflammatory oxidative stress reactions, ultimately leading to endothelial dysfunction and microvascular dysfunction long term. And there's been some seminal papers published on this. As it relates to imaging, there's been some imaging looking at this. There's been, some identification of reduced coronary flow velocity reserve in echo. There's been microvascular functional alterations and endothelial dysfunction alterations in kind of peripheral vasculature that was done on the forearm. And then there was this paper just summarizing what's been done so far on biomarkers and imaging to, one, predict the risk of preeclampsia under pregnancy, but two, to monitor subsequent cardiovascular dysfunction. And in that paper, the section on subsequent cardiovascular dysfunction, there wasn't a lot of data, but it talked about, the importance of this. So we, as I mentioned, kind of looked at females with a history of hypertensive disorders of pregnancy, specifically preeclampsia, and we used OS-CMR. So we're all familiar with the methodology right now, but of OS-CMR, but in this population, we had 35 females who had a normotensive pregnancy in the past and 28 females who had preeclampsia in at least one pregnancy in the past, and some had two. We looked at OS-CMR. The values that I am going to report, the only kind of slight difference from what you've heard about before is that we normalize the myocardial signal intensity to the left and right ventricular blood pools, which we actually think accounts for a lot of confounders. We used a combination of traditional statistics and then some machine learning algorithms. The first one I'll mention is a random forest classifier model for disease classification. So when we look at the cohorts, there was no significant difference in age between the two groups. There was no significant difference in BMI between the two groups. There was no significant difference in the time from pregnancy to participation in the study or scan after. So the baseline characteristics of these groups are all the same. None of the females who had a history of preeclampsia have any overt cardiovascular disease right now. They're not hypertensive things, so they're on no medications. So truly these groups, really the only difference is this, either normotensive or kind of hypertensive disorder of pregnancy. So when we look at OS-CMR, when we look at the midventricular slice, so typically the second slice that we acquire, there is a difference in the kind of global B-more of that slice. So there is a reduction of this B-more in this follow-up period. So maybe it could indicate some global underlying microvascular dysfunction. But when we look at the global signal intensity response across both slices, there's no significant difference. And when we look a little bit further into this, Kate's talk just highlighted this perfectly, is we can see some regional heterogeneity, which we've seen in a couple of different patient populations, which probably reflects some underlying microvascular dysfunction that's patchy and starting. So in this figure, when we look at the left pane there, that's an example of probably a wraparound LAD that has a stenosis and that was revascularized in the cath lab, but you can see the blue shows, reduced B-more in that area. The middle pane here is a healthy volunteer with a nice global response in the green there. And then when we look at this female who had a history of hypertensive disorder of pregnancy, so preeclampsia, it's patchy. And when we average across the slice, you could see that it's possible that when we look at global parameters, this could be not significantly different, than a healthy. But when we look at this visually, there's obviously some regional variations here. And when we look at the parameters of regional heterogeneity, that's exactly what we see, especially radially. And the radial regional heterogeneity is interesting because that's essentially a transmural gradient. So when you think about this strong hypertensive episode in pregnancy, it makes sense that there would be, an endocardial, possibly microvasculature, which was affected first. So I thought that was interesting in this analysis. When we look at kind of machine learning algorithms, this, as I mentioned, the random forest classifier, basically we wanted to look at only OS data. So we had over 3,000 discrete data points of only OS data. And this machine learning algorithm was correctly able to differentiate between normotensive pregnancy and preeclamptic pregnancies with a 90% accuracy. We then started adding in more variables, so change in heart rate, which we've published on before, and both baseline strain and kind of change in strain, so looking at strain after hyperventilation compared to baseline. And we can see that there's differences. So there's no difference in change in heart rate in response to vasoactive breathing maneuvers, which you can see in panel B here. And then C and D just highlight the differences in strain. And when we look at the strain, there's strain differences both at baseline, which is significant, subclinical evidence of dysfunction, but also when we look at the delta strain, so the strain after hyperventilation. It's also significantly different between these two groups. And just visually representing this, on the left, somebody with normotensive pregnancy, their OS-CMR globally looks pristine, textbook response. When we look at this, the circumferential strain, blue here being good strain response, it's also very good with a good heart rate response. We say, you know, over 15 beats per minute change in heart rate after hyperventilation is a good response for us. When we look at somebody who had a preeclamptic pregnancy, we can see, again, this is a different person, this regional kind of heterogeneity in oxygenation response, and then also some strain dysfunction as well, with a slightly low heart rate response, but still pretty good, I would say. We took this a step further, and we actually plugged in not just the data that I've mentioned already, but CMR function, volumetric, all of this kind of data. And we plugged that into a fully automated advanced machine learning algorithm. And we wanted to see if we could identify subclinical changes. So we added LV morphology and volumetrics, T1 and T2 values. These patients also had adenosine first pass perfusion performed. So we looked at the MPRI, and we plugged this into cardiome, which Mitchel will talk about after, I think. So we did this in combination with Area 19. And our cardiome identified the most salient biomarkers to differentiate between those who had a history of normotensive pregnancy and those who had a preeclamptic pregnancy. The most salient biomarkers that it identified were ejection fraction, global BMOR, radial regional heterogeneity, again, very interesting to me, wall thickness, longitudinal strain, and global myocardial T2 values as the most salient features to differentiate between these two groups. And again, there's no overt clinical evidence. It's not like these people have a reduced ejection fraction. All of them have a normal ejection fraction. And when we looked at the ability of this algorithm to differentiate between normotensive and preeclamptic pregnancies, it was able to do it with an area under the curve of 0.91. So a little bit improvement in terms of just looking at OS alone, but still quite significant when we think about there's no overt clinical differences between these two patient populations. So just to summarize briefly, you know, when we use biomarkers derived exclusively from OS, we are able to see subclinical changes in coronary vascular function, notably that midventricular BMOR, and then as well as the radial heterogeneity that we've seen identified. When we use a fully automated advanced machine learning algorithm, we were able to identify subclinical evidence of cardiac remodeling and able to accurately, you know, differentiate between these two groups and identify them. So this approach may be useful to detect persistent myocardial dysfunction in these females and highlight potential areas for early primary prevention strategies. And I think the takeaway from this collaboration is we can use models, machine learning algorithms. As Matthias said, I think this is the future of where we need to go. There's things that we just can't see or compute ourselves that these algorithms can really identify for us. Oh, and the second thing is that OS-CMR can play a huge role in this, in detecting subclinical evidence of microvascular dysfunction, specifically endothelial dysfunction with these vasoactive breathing maneuvers. And in the future, you know, can this information help prognosticate these females after they've had these episodes of preeclampsia in pregnancy? So I hope that was brief enough for you, Matthias, but I think that we're both very excited about this collaboration.
Thank you very much, Liz, for walking us running us through that data set. And I'm also, so Odaime Quesada from the Christchurch Hospital, or Christ Hospital, their team cannot attend today because they have a competing workshop, unfortunately, but they are one of the very important sites because they also will do intracoronary acetylcholine injection to validate this for assessing endothelial function. There's a question from Tom in the chat. Is Liz, is through-plane motion relevant in the interpretation of the SSFP signal intensity? And then another one is OS-CMR be more dependent on the cardiac phase selected for calculation of the signal intensity changes during the respiratory protocol. So the through-plane motion and the phase.
Yeah, so through plane motion for sure is, you know, a consideration for us. I think there's two things. One, we've tried motion correction algorithms which can account for that actually, and Mitchel can speak more to this as well. But that can kind of isolate that through plane motion. But other than that, yes, it is a concern. I think it is a concern with all BSSFPs. But if we're comparing across studies or around the same thing, I think that we're probably okay and just kind of take it for what it is. But we are trialing, as I said, those motion correction algorithms, which I think can account for that a little bit more. For the second question, the B-more is dependent on the cardiac phase. So historically, we use the end-systolic phase. And for a number of reasons. One, there's no cardiac motion. There's more of a myocardial thickness in terms of looking at pixels for signal intensity. But we were also now moving into looking at end diastole as well. And then, as Matthias kind of alluded to, I think Mitchel is going to touch on, when we're actually starting to look at the whole cardiac cycle, so each phase of the cardiac cycle, and you can really see differences each phase as you move through the cardiac cycle. And I think that's the future, not just looking at one isolated phase, but a more dynamic signal across an entire cardiac cycle. So it is very dependent on the cardiac phase, and actually Rohan Dharmakumar, Dominic Gunch has published in the past that it's actually very important that when you're looking at end systolic B-more, which is what we've historically reported, that you are truly in the end systolic phase. If you're one phase off, the values vary greatly.
Yeah, thank you for that clarification. I'm certainly, the question regarding through plane motion is an important one. But I think considering the balanced SSFP or balanced FFE or Fiesta, whatever it's called, between the vendors or through FISP, the signal intensity that you observe, and it's not as critically affected by through plane motion as, let's say, techniques that rely on a slice-specific excitation protocol, such as certain techniques used for T2-weighted imaging, for example, or for perfusion and such. So I don't, also, like Liz said, don't consider this a critical limitation. Okay, so we have talked a lot about, and Liz, you mentioned that artificial intelligence. I think this is a very important aspect here. Artificial intelligence has already reached the whole radiology environment, and of course also including cardiac MR, and the possibilities are really breathtaking, although we all have to be careful to make sure that we validate properly and we do not fall into the trap of enthusiasm that is not justified by the quality of data. However, I have to say, from what I have seen so far, it is really amazing, and artificial intelligence is something that cannot be just done on the side by a group at the university that is looking at cardiovascular imaging. So that's why we worked with students, and in a grant initiative from the province of Quebec, we teamed up with GE and Area 19 to explore this, to dig deeper into more advanced analysis of these scans. And Area 19 is the company that is associated with that. So with that, I wanted to hand over to Mitchel Benovoy, the CEO of Area 19, who will talk about the prototype for the evaluation and what's behind it from a high level. Thank you, Mitchel.
Thank you, Matthias, and good morning, everybody. It's really delightful to see this symposium grow every year. So yes, Area 19 is building the software to analyze these images. Just a quick reminder, Area 19 is a spin-out of Circle Cardiovascular Imaging, for which we entertain a very strong relationship with. But our focus is really to create the ultimate Swiss Army knife tool to analyze OS-CMR, and we're very close. We've put a lot of resources and efforts into developing a tool that will work in your web browser. So there's nothing to install locally. All you need is Chrome or Safari, and that's it. Processing will happen in the cloud. It will be super fast because we're using the cloud infrastructure. And that allows us to perform some very sophisticated AI on the images, number one. And number two, with the data extracted from the images and adding on patient demographics or patient medical history, we're working towards building a comprehensive assessment of cardiovascular health. that will be more holistic than just looking at images. So I'm going to hand it off to Glisant, who is our superstar student. He's a med school student, worked for the lab, and is now, believe it or not, our main developer of the software. A man of many talents, and Glisant is going to show you a very early prototype of the software. And again, notice that this is in your web browser, which is something we're really proud of. Glisant, off to you.
So thank you, Mitchell. So hello again, everyone. As Mitchell explains, today we're going to present a very exclusive prototype of AR19 product called OCG19. And as Mitchell said, this is a fully web-based OS-CMR module. So the advantage of having a web-based module are numerous, but one of the key ones is ease of access without really having to install anything in our computers. So users can navigate to our webpage from any computer and use their login to access their studies and conduct the analysis on the fly. So I'll briefly go over some of our alpha stage features and our envisioned workflow. So here, when the user logs in, all of their uploaded studies will become instantly available from our cloud storage. Just to show, if the user wanted to add a new study, they would just have to click on Add New Patient and drag a file into the box. So now, as that file is loaded, the information will be sent to our cloud-based algorithms that will begin conducting automated segmentation and biomarker calculation. So also, by using our cloud-based segmentation, this means that the computation load on the reader's computer is also significantly reduced. Okay, so when the study is open, the user will be at the quality check step, where they will see these two viewers. They both present two different slices and their appropriate phases that the reader can navigate through. So at this point, our machine learning algorithm would have already generated the contours, done the breathing splits for this study, as well as assigned the correct systole and diastole labels across the acquisition. Note that throughout all of the development of the software, from design to implementation, one of the things that we've kept closely in mind is user experience. We want our application to be easy to use for both experienced users who have done thousands of cases, but also for readers, for new readers or students that are getting started with OS analysis. So one of the features that allows us to do this ease of use is our taskbar. Right. So with one click, the reader would be able to take a look at the assigned tasks for this current stage of the study analysis and keep track of what's to come next. This, of course, facilitates getting started with our module, but also creates a unified workflow across centers that leads to more reproducible results, of course. So here, for example, the user will have to start by using the split handles that are present here in the navigation bar to make sure that the beginning and end of each breathing state is correctly assigned by our machine learning algorithm, so they can easily navigate through these if required. Once that step is complete, they can click complete to move on to the next one. The second step would be ensuring proper placement of systole and diastole labels. And again, the users can move or assign new labels as required. They would also be able to exclude an image if that image quality is not to standard. I should mention also that we plan on adding video tutorials or short animations that would help the users navigate through these different steps. The user would then scroll through the different phases that are present here to make sure that the contours have been indeed correctly identified, and if required, also make edits very easily through this viewers, for example. Once all these steps are completed, the user can now move on to the analysis page. Here, the user will be presented with the calculated biomarkers that are generated from the study using our cloud-based computing. So here you can really play around and select the biomarkers that really make more sense for your study. And of course, you can adapt to new biomarkers as you have more experience with the module and with more studies. Here, what we can see very briefly is the biomarkers that we've calculated, as well as the coronary territories along with their signal intensity graphs. So the user can select one of the signal intensity lines or curves if they want to sort of compare two different biomarkers together. Okay, I don't want to spend too much time here because we're running out of time, but then the user can move on to the report section. And here, of course, the reader can generate a report from the study within the web application. And normally all of these values that you see here would be automatically populated from the study, but in this case, they're not, of course. And so what the user can do at this stage is sort of edit any information that they want, write notes, change the images that also will be automatically populated from the study, and with the click of a button, be able to download a PDF into their computer that they can further print, save, or send to wherever they want. So that's really a very brief overview of what we're working on, but we're extremely excited to finalize this. Thank you.
Thank you very much. And I also want to use this opportunity to thank Area 19 for the great collaboration with the university. It's a very open and transparent and friendly environment. So just a quick question, Mitchel, probably several people will have. When will people have, who has access to that right now, and when will others have access to it, and when is there was already a question, is this commercially available?
Yeah, we're working very hard to have a prototype or an advanced prototype version available for OS-CMR in January, where we'll start rolling it out to some interested collaborators. We're going to do a phased rollout to gather feedback and be very iterative on this process, but definitely end of Q1 and Q2 of next year, we should have something that would be usable by most centers here. And I see a question by Kady here about data leaving the jurisdictions of the hospital. Extremely important question for European collaborators. Although the architecture of the software is cloud-based processing, we can deploy this locally also within hospitals almost seamlessly. There's just a few more minutes of setup time in that case, but we can certainly support purely local processing where the data never leaves the hospital walls.
Okay, thank you very much. So if there are not any other urgent questions, some will still go on in the chat. I wanted to, before I hand over to Maggie, I wanted to ask some questions myself, and I hope I can do this properly. My first question is, and you will have that in the poll, there should be a window somewhere. How many of you are a member of the OS-CMR Special Interest Group on OS-CMR? Just want to get a feeling. So find that poll window and just pop it in there. So this is not to beat the marketing drum for that. I'm just was wondering to what extent we could discuss topics here. So I see a relatively even distribution. So for those of you who are not a member, if you're an OS-CMR member, it's free. You just can join, and we will have. Once established, we will have newsletters, we'll exchange information, we will use meetings at the OS-CMR to exchange our experience to help each other with research. I think in these times where we have the technology to connect that easily, we have to do that in order to mutually support us. As I said, once you're a member of OS-CMR, this is free. But okay, so we have still we have about 40% of those of you are here. So then I will ask another question very soon. But then first, the next question I had was this one here, and I give you a little bit time. Oh, sorry, not this one here. I give you a little bit more time. So in which areas are you planning to perform research using in OS-CMR? If you plan to perform research, then just type it in. It will be anonymous, so but it gives us an idea of how many, oh, sorry, can I not launch that? Or is it already launched? Okay, I may need some help now because I apparently cannot launch it. Danny or Liz, could you try to launch that? And this is just to make sure that when we have this collaborative research going worldwide. Oh, sorry, I have to end the poll. I think that's it. So here are the results. Okay, so then this is the other one. No, I can still not launch it. Okay, so I hope that Liz or Danny hear me and can allow me to maybe, oh, okay, now I needed to stop sharing. Okay, so this is the other question. If you're doing research in cardiac MR with oxygenation sensitive techniques, what is the research that you are that you're doing, so that we can say in the special interest group, hey, we need more people who do this and that, and there's just very broadly, so there's no, hopefully no nothing to sensitive to disclose here. And then I would ask Danny or Liz to pose the question, how many of you or who of you thinks that we should have a special meeting at the OS-CMR symposium, and we will then see what topics would be interesting. So maybe you can launch that poll after we are finished with this one. So we're seeing that 44% currently the lead are interested in non-ischemic cardiomyopathy, and then followed closely by coronary artery disease comparison with first pass perfusion. And then two other frequent ones are coronary artery disease comparison with clinical standards, QCA. And amazing that there's such a strong interest of cerebral vascular disease. I guess the data that we had seen in anxiety sparked some interest, and maybe people have also heard that before about some of these results. So this is great to see. And then as an addition to other research projects is 21%. I think that's a good idea because it just adds a few minutes and you have some information on coronary vascular function. So we still have a response rate of close to a little bit more than 53%. For those of you who have not participated, I assume that you're not planning active research, but more following the field like this. Okay, so thank you very much. This is, I think this is very helpful for understanding which fields may need some additional. So I think cost efficiency, we have started a program in Nigeria where cost efficiency is very important. One of our students went there and trained them in OS-CMR. They have a strong interest in having a cost-efficient method for coronary vascular function. So cost efficiency is maybe one of those topics that we have to push more. We also work with a center in India, in Vellore, and yeah. So question, should we have a special meeting at the OS-CMR symposium? Okay, it sounds like this would have been a rhetorical question. So there's overwhelming. So, okay, I will go ahead and ask for such a symposium at the OS-CMR level for the next OS-CMR in London, so that we can in face-to-face dig deeper in some of the questions. Thank you very much. Regarding the discussions, are there any critical points some of you would want to bring in? So there's Javad, thanks for the question. Could we extend the images to have long axis images? So this points to a very critical, let's say, limitation. that we of course have. Currently, we can do 2 slices. So with 2 slices in short axis views, the way we do it right now is that we place one slice in the basal, but basically touching the mid slice or the mid section, and then one we place in the mid section, but touching the apical. So not going into the apical, but touching it. So this gives us one quote-unquote basal, one quote-unquote mid slice. This is the best what you can do with short axis views. With long axis views, and this is what we have to explore, a 3 and a 4 chamber view would give us all territories and would give us a relatively large territory. And I know that Mitchel is already looking into how difficult or possibly it would be to evaluate these images also automatically. I personally like long axis approaches in general, be it for LV function or for perfusion. So we will definitely explore that. For now, also in terms of comparability with other first pass perfusion and late enhancement, which typically are abundant available in clinical medicine. That's why I think for this phase, it's probably easier to do that with short axis views. Another topic I wanted to bring up, and I see Mona, you're still there, and it looks like you would be close to a lighthouse, but that's of course your background. So Mona is a PhD in Germany, and we have started thinking about improving the sequence. So maybe the sequence has been used like that for years now, and people seem to be happy with it. But do you see any need or opportunities to further improve the sequence, especially when we talk about coverage, number of slices, etc.? You're muted.
Hello, everybody. I think this is it depends on which MR scanner you want to do the measurement, because I think this is the big problem is that if you speak about the TrueFIS or BSSFP, you don't have the same sequence on all of these machines, GE, Philips, and then the Siemens. And because of that, I think this is the first step is to have the same sequence or the same technique on all of these for all of these vendors. And the second thing is to have maybe acceleration techniques to have more slices, not only two slices, but maybe from the apex to the basis. It depends on the volume of the heart, more than 3 or 4 slices.
Yeah, that would be, of course, fantastic. Of course, we still also need a relatively high tempo resolution, because we are looking at a 30-second time frame where we will be able to see significant differences. And during these 30 seconds, we have to acquire as many data sets as possible so to generate a curve. But your work there is very much appreciated.
Yeah. I thought about that. Maybe the readout which you use at the moment is a Cartesian readout. Maybe we have to change to the radial one and then to use the compressed sensing on the other acceleration techniques in order to have more volume within a short time.
Yeah. Okay. So thank you very much, Mona. Are there other important aspects or things you want to announce or talk about here? Anybody? I see that there are some really some people on the call who will provide a lot of input. I see Vasvi Singh, I see Sophie Marroheni, and so this work, I also Ming Yen. So your interest in your work will be critical in this field. Okay, so now we move basically to the, I don't want to call it post-workshop, but to the kind of the practical part of the workshop. And I would ask Maggie to just, and this is a short but very efficient presentation on what are the critical points in actually performing the MR. So Maggie, this is especially interesting for people who actually perform the scan, are the scanner, but I think everybody who's involved in the research at this stage should be aware of these. So Maggie. And Maggie, I should say, is our chief technologist for cardiac at McGill University Health Center, and very experienced in that field, of course.
Good morning, everyone. Thank you very much, Dr. Friedrich, for that kind introduction. So yes, my name is Maggie, and today I will discuss with you just some very important key points and must-haves for an overall successful OS scan. So, to begin with, patient preparation is not only essential, but like Liz and Lucas had mentioned, it is key for a successful OS scan. The first introduction that we have to the breathing maneuvers with our participants is done outside the scanner room, where we typically screen our patients for MRI safety. And then we begin with an explanation of the technique and answer any and all questions that may arise. Then we will proceed to the video presentation. And here, when we show the video, the model here purposely does not breathe correctly. And he is corrected, and notice how then he breathes. Well, you cannot hear the metronome, but he's breathing in sync with the metronome, which is very, very important. Our next phase of teaching happens once we're inside the room, and we have an in-room practice. So once the patient is on the table and the bellow is around their waist, we practice using the IROC on the gantry, and we visualize, we verify the respiratory gating just to make sure that they have indeed grasped the technique. Now, in all OS scanning, a baseline or scout is very important, and that consists of about a 10-second breath hold, which is done and captured in a comfortable and expiration breath hold. So the first slice, how do we plan them? The first slice is a mid-basal slice, which is strategically placed to avoid bicuspid and tricuspid valves and the flow artifacts originating from these valves. The second slice is a mid-ventricular slice. We go through the cardiac cycle just to verify positioning. Please note the shim size. It is a focused shim around the two plant slices and not the entire heart. Now, these scout images serve several purposes. One is to verify that both short axis slices have good image quality, are void of artifacts, and are well positioned. They are also essential for signal intensity comparison that will be done later using the post-hyperventilation breath hold. Now, once these images have been verified, then we may proceed to the continuous acquisition sequence. So with our continuous acquisition, I will show what is expected in each segment of the continuous acquisition sequence. So the first is during the free breathing. Now here, as you can see, the images look blurred, and that is expected. And this is a common question from sites that are new to the OS sequence. They say, oh, there's something wrong with my sequence, or am I doing something wrong? Absolutely not. It is expected to be blurry because the participants are breathing right through that segment and portion of the sequence. The next segment is the hyperventilation. And the images, as you can see here, look pretty awful to the point that you may not be able to even distinguish the myocardium. Actually, something like this is perfect because not only is it expected, but it also confirms to the readers that the hyperventilation was done properly by breathing deeply and rapidly. On the other hand, the breath hold sequence must be sharp, which validates a proper breath hold was done. Now, this is where most of our data is collected and acquired. So it is important to mention also to the participant that during that long breath hold, if they want to take a little breath in or a little cheat breath just so that they can hold their breath longer. Any images acquired after that breath, that premature inspiration, it cannot be used. So once you finish your continuous acquisition sequence, just verify that you do indeed have 3 full cardiac cycles for us to analyze. And if you don't, you need to wait about 2 or 3 minutes for the heart rate to go back down to resting heart rate. And then we need to repeat not only the continuous acquisition, but very important, you also need to repeat your OS scout. This next slide, I will discuss just some common artifacts that you may or may not see and what to do to correct them. So the first one is a motion artifact that you may see. And here you can see the vertical streaks right through the heart, through the chest wall and out. And this sometimes happens when your participants fall asleep during a breath hold sequence. So you basically make sure they're awake and you just repeat that sequence. And some participants prefer to do 2 breaths before holding for 10 seconds. So we can also do that. The next artifact is, you would actually see these ringing artifacts probably on the older machines, systems. So it's a ringing artifact, and you can appreciate it here on the myocardium. You see the dark and then light, dark lines. And these are ringing artifacts occur when there's a strong contrast between adjacent anatomy or when you have a very low matrix. So how do we correct this? You may repeat with a higher matrix or use a K-space filter for this. And the next, and which is the most common artifact that you may encounter, is a BSSFP or susceptibility artifact seen in the infralateral portion of the myocardium as seen here. So here is the artifact and it's overlapping here part of the myocardium. So what can you do to get rid of this? You can try swapping your phase and frequency encoding. You can look at your shim, adjust it if you need to. Or one of our go-to solutions on our 3T is to do a frequency shift of -70, which will, as you can see here, which will not get rid of the artifact, but it will move it away from your area of interest. So now you see that your myocardium is free of artifacts. And so we urge you that whenever you see any type of artifact on your myocardium, to repeat, because you can potentially risk missing some very vital information if you have a myocardium with artifacts on it. Okay, so last but definitely not least, I will demonstrate what adequate and accurate breathing should look like. So on this first snapshot of a video that I had taken, we see the participant transitioning from free breathing, which is right here, into the hyperventilation. Okay, so note the difference of the respiratory gating, and also, and notice how when it's done properly, how the respiratory rate right here reaches 30, and this is only about after 5 deep breaths. On the next slide, here's the next snapshot, and this is the participant transitioning from hyperventilation to the breath hold portion. Okay, and so here the patient throughout the whole minute was hyperventilating deeply and rapidly, as we can see here, because the respiratory rate is at 30. And then with the automated voice, we'll ask to breathe deep, breathe in, out, and hold your breath. And it is very, very important to hold your breath in a comfortable end expiration and not a forced expiration, because then it would be very difficult for you to hold your breath for the 40 seconds that is required. So in conclusion, the OS scan is a fairly simple technique that can easily be implemented and adapted. The aforementioned important points and must-haves are crucial for good image quality and a proper and successful execution of the sequences. So if anyone is interested in doing a test scan, or if you simply have a few scanning questions, by all means, please reach out to Liz Canitas, and she can set up a Zoom meeting with your site, and we'd be glad to help. So thank you very much for your attention.
Thank you very much, Maggie. If there are any questions regarding the practicalities, feel free to send us an email. We have also a starter package that includes video and also other material that is useful. So with that, if there are not any urgent questions, I want to conclude the symposium or the meeting. And I want to thank the participants, but especially the speakers. We had close to 100 attendees. This is even for high-profile online meetings. This is a high turnout, so I'm very happy about the interest, and I hope this was interesting for you. And if you are in the research, wish you all the best, and we're always there to help. We have also other centers that have started to gather a significant experience, like Heidelberg. We have Lucas Weverling in Amsterdam, and of course Bern, Kady Fischer. So there are a lot of people who can help and share experience, and like with many CMR research activities, there's a very open and friendly spirit. So this makes it a pleasure to work in this field. So I wish you all the best, and see you next time. Latest maybe at the ACMR for our symposium. Take care, everybody. Bye-bye.